This 40-year-old non-smoking female patient shows multiple Miller Class I gingival recessions on teeth 2-2, 2-3 and 2-4, both for aesthetic reasons and to facilitate oral hygiene. The patient wishes a coverage of those recessions. The affected area has been anesthetized by local infiltration anesthesia. An intrasulcular incision is applied on the facial side from the center of tooth number 2-1 to the center of tooth number 2-5. For this step, a key dent microblade is used. A straight tunneling scalpel from the burner set is placed in the incision line to mobilize the facial tissue. This instrument should have permanent bone contact to avoid perforation of the flap. A full-thickness flap is carefully mobilized up to the mucogingival junction with the same tunneling instrument. After crossing the mucogingival junction, it becomes a split-thickness flap. The flap is mobilized any more laterally. For this part of the process, the angled tunneling instrument is used, which also guarantees better tunneling and elevating of the papillae. To avoid tearing, the papillae are carefully detached from the underlying bone. The denuded root surfaces are cleaned and smoothed with a greasy curret. All plaque or tartar residues must be removed in order to create a biocompatible root surface. Sharp edges on the mesial and distal line angles of the root should always be smoothed. If required, a rotating tool may be used as well. This is another important step for a successful treatment, for which you need to take your time. With the angled tunneling scalpel, the tunnel is extended by one tooth both mesially and distally in order to make the flap more mobile. The Scullion Arroca tunneling instrument is used for the further interdental preparation. The papillae are completely mobilized now. The mobility of the flap is checked with a straight periodontal probe. The stress-free mobility of the flap can be seen clearly. The buccal gingiva is insufficiently thick. A subepithelial soft tissue graft is needed to stabilize both the flap and the papillae, and thus to increase the thickness of the buccal soft tissue. The required length of the graft is measured with a periodontal probe. The palatal side has been anesthetized before. An incision is made perpendicularly to the palatal bone at a distance of about 2 mm to the teeth. This incision begins on the mesial surface of the second molar and is extended to the distal surface of the central incisor. A small scalpel with a number 15 C blade is used. The second incision is placed parallel to the mucosa and has a width of about 5 mm. This incision separates the palatal epithelial tissue from the underlying connective tissue. The connective tissue is detached from the bone with a periosteum elevator. The third incision is made perpendicular to the bone in order to harvest the connective tissue graft. The connective tissue graft has an adequate length and optimal thickness. To protect the transplant from contamination, it's immediately covered with a sterile saline-soaked gauze until use. The palatal incision is closed with a continuous cross-stitched suture with monofilament 5.0 suture material. The previously cleaned root surfaces are conditioned with Straumann Pref gel for 2 minutes in order to remove the smear layer and expose the collagen matrix of the dentine. Straumann Emdogain is applied to the connective tissue in order to create a suitable environment for proliferation and differentiation of the cells contained in the graft. After 2 minutes, the Straumann Pref gel is completely removed from the root surface by thoroughly rinsing with sterile saline solution. Before the application of Straumann Emdogain on the exposed root surfaces and beneath the mucoperiosteal flap, any contamination with blood or saliva must be avoided. This is a crucial step to allow the precipitation of the animal matrix proteins on the root surfaces and thus to facilitate periodontal wound healing and the formation of root cement, periodontal ligament and alveolar bone. To draw the connective tissue graft into the tunnel, a 6.0 monofilament suture is placed in the distal portion of the flap. Conducted by the blunt end of the needle, the thread is pulled underneath the papillae afterwards. Then the graft is fixed with a mattress suture at a distance of about 2 mm from its tail, in order to avoid tearing it. A specially designed tissue forceps ensures that the needle is precisely placed in the graft. Then the graft is inserted into the tunnel by gently pulling the thread and pressing with a periodontal probe. Care must be taken not to damage the papillae. The graft is mesially secured with a mattress suture. Before suturing the distal part, the graft is gently stretched. These two sutures prevent a displacement of the graft in the tunnel. The graft is additionally stabilized by loops with a 6.0 monofilament suture material. Then the blunt end of the suture is pulled through underneath the mesial interproximal space, while the free end remains palatally. The suture is placed into the graft from buccally and again pulled through underneath the mesial interproximal space. The suture is looped around the tooth, running underneath the distal interproximal space. And is stitched into the graft from buccally again. The needle is once more inserted under the distal interproximal space and the knot is tied palatally. This suturing technique is used for securing the graft to the teeth number 22, 23 and 24. A special tissue elevator is placed between the flap and the graft in order to prevent touching or displacing the graft. This tissue elevator is needed to guide the needle. The advancement of the flap towards coronal, which ensures a complete and stress-free coverage of the recession and the flap, is performed by single-loop sutures with 6.0 monofilament suture material. At tooth number 21, the suture is conducted underneath the mesial interproximal space, around the tooth and back underneath the distal interproximal space, whereas the blunt end of the needle is used as a guide. Then the knot is placed buccally. At tooth number 22, the flap is sutured from the outside to the inside. The suture runs under the distal interproximal space, around the tooth, and from the outside to the inside of the flap. The tooth is again looped and the knot is placed buccally. The same suture technique is applied for the coronal advancement of the teeth number 23 and 24. An optimum and stress-free stability of the flap has now been achieved, which prevents a displacement of the flap and the graft during the healing process. This is another crucial factor for a successful treatment outcome. The small exposure of the graft, which can be seen at the first incisor, has no negative impact on the treatment results. This picture shows the multiple Miller Class 1 gingival recession defects on teeth number 22, 23 and 24 before treatment. The clinical situation 12 months post-operatively shows complete root coverage, optimal tissue adaptation and thicker tissue at all 3 treated recessions. An optimal clinical result has been achieved by the modified coronally advanced tunneling technique combined with Straumann Emdogain and a palatal connective tissue graft. With this treatment, the aesthetic demands of the patient are fulfilled.